This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you. I think I've drawn this short straw by being the last speaker, but also filling in for someone who's not here. Dave was actually doing this paper on behalf of Yen Ing, who's a Bachelor of Nursing Honours student who also has an IT background. And so this has been passed the baton, so to speak. So, of course, the background to this is that deterioration after ICU discharge is very common, and we have 5% of patients are readmitted to the ICU in Australia and New Zealand. And, of course, at this stage, 1 in 3 deaths occur after discharge from the first admission to ICU. So can we actually predict who will deteriorate after ICU discharge? And we have available to us quite a number of databases now and the ability to link, and we've heard a number of papers presenting that data mining and data linkage today. So we've got, in terms of the ICU discharge data, we've got the characteristics on admission, patient characteristics at discharge, therapies present at discharge, and also the discharge location and the timing of discharge. And actually the decision to when someone's discharged, but when they actually get discharged. So this study is a retrospective cohort observational study, and it was conducted at the Alfred Hospital from the 1st of July 2012 to the 30th of June 2014, and it was all patients who were discharged from ICU to the wards, and it linked up 4 databases: the ICU database, the hospital administration data, administrative data, which is admission and discharges, the riskman data, which is associated with MET and code blues, and also the pathology data. And the analysis is univariate and multivariate analysis. I'm going to just preface this that I am not the statistician on the team, and so Dave will be here tomorrow, so if anyone's got statistical questions, hold them for him, please. So we were interested in only those who were discharged alive to the ward and at the end of their first ICU stay. And you can see there were 5,392 ICU admissions over 2 years, 4,632 were live discharges. These are the outcomes of those discharged from their first ICU admission. So there were 2.3% died, 6.5% were readmitted to the ICU, 19% were medical emergency calls, and 1.1% were code blue calls. So the main outcome that we wanted to consider was one or other of MET, code blue or readmission, and the patients could have had one or more, for example, any readmission which was a result of METs. We didn't try and predict deaths after ICU admission, which, although possible, but because of John Santamaria's work with the DARE study, shows that these are heavily influenced by different treatment limitations on discharge from ICU. Then we looked at all the factors that were different between those who deteriorated and those who didn't, and there were lots, hence the next mental slide. This is a really busy slide, and just to show you how many variables there were, which was greater than 200, and that these were just the ones which were different between those who deteriorated after ICU discharge and those who didn't. And a lot dropped out after the multivariate analysis. And to note, we had no physiological data available at ICU discharge. These were all combined into a predictive tool using bootstrap logistic regression, which had a reasonable discrimination with the area under receiver operator curve of 0.77. Some summary finding examples from the logistic regression: the Apache score was not predictive, but some of its components were. Bradycardia at ICU admission was predictive, but not tachycardia. Both high and low temps on admission to ICU. Discharge location and unit were important, and some surprising factors. Abnormal ALP at discharge from ICU was predictive. A high potassium of greater than 6 was predictive, and we were amazed to see that we actually sent anyone out with a high potassium. Each patient was given a predictive chance of deterioration after ICU, then stratified patients into high and low risk groups and looked at how well our predictions matched what happened to the patients. Although the predictive tool was to develop to predict METs, code blue or readmissions, it appeared to work equally well if we wanted to identify patients just at risk of METs, which are the dark bars, or just at risk of readmission, which are the lighter purple bars. And then stratified by patients at risk of death after ICU, which are the very light mauve bars. We could predict overall numbers of deteriorating patients in each group. This is the number of patients in each group, and a high number of young people because of the trauma population at the Alfred Hospital. This shows the number in each age group who have MET, code or readmission. And the same data as the previous slide, but just shown as a percentage, and also demonstrates how age appears as a risk factor. The black dots show the number we predicted to deteriorate, or pretty close. So, deterioration after ICU discharge is predictable. Using a combination of factors present and available from hospital databases is possible to predict overall numbers of patients who may deteriorate after ICU discharge. But this needs validation in other cohorts, more recent patients, and its ability to predict individual patient risk is not the same as being able to estimate overall numbers of patients who deteriorate. It can, however, give us more information about other ICU practices, such as exit block. Prediction tools such as this allow us to investigate other ICU practices. This shows exit block, which is the time between decision to discharge and actually leaving the ICU. When we plot the risk of deterioration against this, there appears to be a protective effect by staying in ICU longer, and adjusted odds ratios plotted on the same graph. So using a combination of factors present and available from hospital databases, it's possible to predict overall numbers of patients who may deteriorate after ICU discharge. The use of these and other prediction tools need further research, and I think that it's interesting that we still all recognise that there will be a group that we can't predict. Thank you.